Hello students, in this video we are going to discuss about recurrent pregnancy loss. See, recurrent pregnancy loss or recurrent miscarriage is the loss of pregnancies, that is, we can keep a number of more than 3 loss of pregnancies, okay, after 20 weeks of gestational age. Okay, and remember, these pregnancy losses should be a documented pregnancy loss, that is, it should be a prior confirmed pregnancy by either ultrasonogram or by histopathological examination. Okay, so definitely ectopic pregnancy, molar pregnancy and biochemical pregnancies also are not taken into consideration. Clear? So, these are not taken into consideration. Clear? So, we will come up again with the definition of recurrent pregnancy loss. Recurrent pregnancy loss is a pregnancy loss that has happened more than or equal to 3 times after 20 weeks of gestational age, and it should be a documented pregnancy that was done by ultrasonogram or histopathological examination. Clear? Now, even then the definition says more than 3 pregnancy losses. Investigations can ideally be started after 2 pregnancy loss also. Okay? Clear? Now, if we take recurrent pregnancy loss, it can be divided into 2 types. Okay? One is a primary RPL, that is recurrent pregnancy loss. Okay? So, primary recurrent pregnancy loss means multiple losses is happening in a woman. She never had a live born child till now. Okay? So, multiple losses in a woman who has never delivered a live born. Clear? So, I hope you will be able to come up with the other type of recurrent pregnancy loss in the definition also. Yes? Okay. So, it is secondary RPL where multiple losses in a woman who had a prior live birth. Clear? Now, we will see the etiology for recurrent pregnancy losses. There are so many factors that will be playing for this recurrent pregnancy loss. The first factor is epidemiological factors. Next one is some of the genetic factors, and next comes the anatomic factors, and next comes the endocrine factors. Also, the immunological factors, and even after evaluating all these things, some of the cases can remain unexplained. Okay? So, if you ask me, ma'am, among this which is the most important? The most important among this is the endocrine causes, okay, which is most commonly seen, and it accounts for 10 to 50% of the cases. Okay? Now, if you ask me which is the most common cause among this list, it is going to be the endocrine causes, which constitute about 50 to 60% of the cases. Okay? The second place goes to the anatomical factors. Okay? If we arrange them in order from the high risk to low risk category, we can take the endocrine factors. If we arrange in order the factors from high risk to low risk, you can take the endocrine factors first, followed by the anatomical factors, followed by the immunological factors and the genetic factors. Clear? Now we will see in detail what are these factors and how they are going to influence our behavior. Okay. So first one is epidemiological factors. So in this, the first important thing is parental age. Okay. So if you take the mother when her age is more than or equal to 35 years, and if you take the father whose age is above 40 years, there can be a risk of RPL. Okay. And remember, obesity can also be a risk factor. Okay. Obesity can also be a risk factor. So what is the BMI range? More than 30 kilogram per meter square. Clear? And next one, we are going to see about the genetic factors. Okay. So genetic factors are usually the most common cause of sporadic loss. Okay. But if you see, among the couples, 2 to 5% of the couples can have translocations, okay, especially the balanced translocations, which can become unbalanced translocations when passing on to the fetus, okay, and that can result in recurrent pregnancy loss. So, 2 to 5% of the couples may have translocations, okay, in either partner. Okay, that can be a balanced reciprocal translocation or a balanced Robertsonian translocation. Clear? So, we will see balanced reciprocal translocation first. Okay. See, most of the times this translocation is seen in the mother. Okay. And what happens is that when the mother is having, it will be a balanced translocation. But whenever it is going to the fetus, it becomes a unbalanced translocation. Okay. Unbalanced translocation means it can result in either addition or deletion of the chromosomes. Okay. Either there can be addition of chromosomes or deletion of chromosomes. So, what it will lead to? Yes, when addition, it can lead to trisomy, and when deletion, it can result in monosomy, and we all know trisomy happens more than monosomy. Yes, so this can result in recurrent pregnancy loss. Clear? And what about balanced Robertsonian translocation? What is balanced Robertsonian translocation first? There is a chromosomal rearrangement in 5 of the acrocentric chromosomes. Okay, what are the chromosomes? 13, 14, 51, 21 and 22. Clear? So, there is chromosomal rearrangement in these chromosomes, and whenever there is a balanced Robertsonian translocation is present, it will lead to recurrent pregnancy loss. Okay. Next, we will see about anatomical factors. See, in anatomical abnormalities, we can have structural abnormalities. Okay, whenever there is a structural abnormalities in the uterus, either it can affect the implantation, or if suppose the implantation has taken place and the fetus is going to grow, it will interfere with the growth of the fetus also in different ways. Can you understand the concept? So, in that way, it can now cause recurrent pregnancy loss. Okay. So, first one is structural abnormalities. Okay. So, it can cause either impair implantation, okay, or it can impair the uterine distension, okay, during the development of fetus. Okay. The first credit here goes to submucous leiomyoma. Okay, a leiomyoma, okay, especially a submucous type. Okay, so this is a hysteroscopic picture of submucous leiomyoma. Okay, you are able to see the growth and the vascularity, right? So what is going to happen is, this can interfere with implantation, and both diagnosis and management can be made by hysteroscopy. Okay, so you may need a hysteroscopic resection. Clear? And the next one is Asherman syndrome. See, in Asherman syndrome, let us take, this is the normal uterine cavity. Okay, like this and like this. Okay, what is going to happen in Asherman syndrome is, there can be multiple uterine scarrings or bands, okay, that can be seen. Okay, sometimes these bands can be thin, or even these bands can be dense also. Okay, so actually if it is a normal uterine cavity like this, only the implantation can happen and the development of the baby can happen without any interference, right? But when there are so many adhesions is like that, what is going to happen is, the whole cavity can go for a obliteration, and further implantation and the growth of the fetus is not that much possible. Okay, we'll see what are the causes for this Asherman syndrome. Number one is uterine curettage. Okay, for example, if the curettage has occurred due to suppose amidst any cases of abortion. Okay, and while doing curettage, what happens is, there can be depletion of the endometrium. Okay, so depletion of the endometrium can occur, and this can result in adhesions, because already we have studied the endometrium is going to be the regenerative layer, right? But if this is not there, what is going to happen is, there is going to be a numerous band of adhesions being formed between the myometrial layer. Clear? And not only this, some other causes, like suppose if she has undergone surgery for myomectomy, or even a previous cesarean section, okay, or suppose if she is having a intrauterine contraceptive device, okay, and there is a infection due to that device. Okay, so all these can cause Asherman syndrome. Clear? We can diagnose this Asherman syndrome by hysterosalpingography or saline infusion sonography. Okay. Now in this, what we will be able to see is, you will be able to see multiple filling defects in the uterine cavity. Okay. However, definitive diagnosis is made only by a hysteroscopy, and this will remain as the treatment modality also. Okay, for treatment we will be doing a hysteroscopic adhesive lysis. Clear? Yes. Next one is endometrial polyps. Okay, what are polyps? Again we have the uterus. Okay, so polyps are something, okay, that are distending into the uterine cavity. Suppose if it is a pedunculated polyp, it will have a pedicle, right? So any mass, okay, mass extending from the uterine wall into the endometrial cavity. Okay. So, that is a polyp. Definitely, this is also going to impair with the implantation, right. One important USG color Doppler finding of polyp is a single feeding vessel reaching the mass. Okay. Now, management. Yes, we can do a hysteroscopic polypectomy. Clear? So, this is a picture. Okay. You are able to see the uterine cavity where numerous polyps are there. See, this is a pedunculated polyp. Okay. Pedicle is there. Okay. This is a pedunculated polyp where you are able to see a pedicle. Okay. And this is a single feeding vessel. Okay. That is coming to the polyp. Okay. A single line of feeding vessel in case of polyp is seen. Okay. If you see this, it is suggestive of endometrial polyp. Okay. Not only these things, but also cervical lacerations, okay, that happen during previous pregnancy, okay, can also lead to recurrent pregnancy loss. Okay. For this, how you will manage? Yes, simple. You have to do suturing of the lacerations. Clear? Now, we will see some congenital malformations that can lead to miscarriage. Okay. So, congenital malformations in the uterus that can lead to miscarriage. Yes, very important. Okay. Septate uterus. Okay. Septate uterus is one of the most common cause of recurrent pregnancy loss. Okay. And especially it is associated with first trimester miscarriage. What you will do? Yes, it is again hysteroscopic septal resection. Clear? We will see the picture of septate uterus for better understanding. See, there is a septum. Okay, a septum can be partial septum or a complete septum. Okay, here there is a picture of complete septum where it is extending from the fundus, okay, and into the endometrial cavity, and here there is a partial septum where it is partially extending into the endometrial cavity. Clear? Next one is very important topic and concept in recurrent pregnancy loss as well as for your clinical knowledge also. Okay. So, it is cervical insufficiency or cervical incompetence. Clear? Next one, what we are going to see is about cervical insufficiency or also known as cervical incompetence. Okay. So, this is one of the important topic both theoretically and clinically. Okay. So, what is going to happen is in a normal pregnancy, okay, for the retention of the uterus inside the, what is going to happen is in a normal pregnancy, a cervix will be usually closed with a mucus plug and this will be continuing till term and the mucus plug will be released only during labor, right? But what is going to happen in incompetent cervix is the cervix is going to open up very soon in the second trimester itself. Okay, and most of the times this won't be associated with any pain. So, there is painless cervical dilatation as well as no uterine contractions also. Okay, no uterine contractions. But what is going to happen? The membranes are going to bulge out through the cervical os and it will go for rupture and finally it will result in expulsion of the fetus. This happens in the second trimester itself. Okay. We will see some risk factors for cervical incompetence. See, there can be some of the congenital causes also. Okay. See, congenital causes occurs when there was in utero exposure to diethyl stilbestrol. Okay. In utero exposure to diethyl stilbestrol. Okay. So, what will be happening in this cases? There is uterine and cervical hypoplasia that will be resulting in cervical incompetence in the second trimester. Clear? In her pregnancy. Okay. And the next causes when she has a history of preterm labor. Okay. And in this pregnancy she is carrying multiple gestations. So, multiple pregnancy now. Not only this, there can be some of the acquired causes also like dilatation of the curettage and amputation of cervix. Ideally, this can be diagnosed by USG between 18 to 24 weeks of gestational age. You can check for the cervical length by ultrasonogram. Okay. What is the normal cervical length? Yes, between 3 to 4 centimeters, right? Suppose in the USG, okay, you are seeing a cervical length less than 2.5 centimeters, then there is funneling of the cervix, okay, with changes in the forms of the cervix. Okay. First it will be T-shaped, yes, then it will become Y-shaped, then it will become V-shaped, then it may become U-shaped. I will show you the pic, wait. And there can be protrusion of the membranes also in Seetha canal. Yes, that is understood, right? And sometimes presence of fetal parts in the cervix or vagina. Clear? Now, let me show this pic. Okay. So, if you see this pic, you are able to understand that, yes. So, this is the cervix, right? Okay. So, there is funneling, means there is minimal opening up of the cervix. Okay. So, if you see here, this is a T-shaped funneling first. Okay. So, you are able to see this T, right? And similarly, there will be a Y-shaped funneling like this. Clear? And then a V-shaped funneling. Okay. And finally, it is going to be the U-shaped. Okay. So, similarly in ultrasound also you will be able to make this diagnosis. For example, if you see here, so this is a T-shaped funneling. Okay. So, this is a Y-shaped funneling and here you are able to see a V-shaped funneling. Okay. Just like that. And this is a U-shaped funneling. Clear? Okay. And sometimes the patient may directly present with the cervical incompetence. So, making a clinical diagnosis is also important. What you will be able to see is, you will be able to see a fully dilated cervix, okay, or partial dilated cervix, whatever. There will be dilatation of the cervix with bulging up of the membranes. Clear? Now, this is fine. Now, we are talking about RPL. So, if you ask me, ma'am, can we diagnose it before this happens? Yes, it can also be diagnosed in a non-pregnant female also. Okay, but the diagnosis is not reliable as much as we do during pregnancy, okay, using ultrasound.